Let's talk about chronic hepatitis in pregnancy. And some of this is controversial, and Eric, please jump in if you think I say something that is incorrect. Next slide. So prenatal testing, we've been doing hepatitis B surface antigen testing for 25, 30 years now on everybody, because we knew that risk factors only picked up about 50% of patients. So hepatitis C antibody has been recommended since like 2018 or 2019 by ACOG and the CDC to test to see if somebody has a hepatitis C antibody and to determine if they're a chronic carrier. I know that there's some people on the phone or on the Zoom call that actually also takes care of GYN patients. It is recommended by the CDC and ACOG that every adult be tested at least once in their life. I still think probably half of us are missing this on our prenatal labs. And so for the educators, please make sure our groups know about this or add it to their prenatal labs. Next slide. So hepatitis B, this is a busy slide that you can actually get from ACOG Practice Bulletin. It was literally just updated about a year and a half ago. So we screen with hepatitis B surface antigen, and if that's negative, we stop, okay? People who have been vaccinated will be positive for the hepatitis B surface antibody, okay, not antigen. So if we get somebody who is positive for the surface antigen, then the question we have to decide, is this a chronic infection or not? The thing that really stands out is if there is an antigen positive, the surface antigen positive, and the surface antibody is negative. Go back, please, Rachel. So the definition is primarily hepatitis B surface antigen positive and antibodies to surface antigen negative. Okay. Normally the core shows up, the core antigen shows up before the surface antigen, and so the core antibody is made before the surface antibody. So I'm not going to go through all this little chart, but you can keep it if you want to see who's susceptible, who's acutely infected, and who's chronically infected. Next slide. I used to hate this. I don't know about Eric. We were always tested on these graphs and curves on CREOG in our exams. The hepatitis B surface antigen actually appears before the symptoms, hepatitis surface antigen, and the B, E antigen. And then their antibodies appear, the core antibody, the hepatitis E antibody, and hepatitis B surface antibody is usually the latest one that shows up. It shows up approximately 30 28 to 32 weeks after exposure. So in my opinion, we're seeing this less and less with the vaccination, but we still occasionally see it. Next slide. So again, chronic hepatitis B is defined as the antigen positive, the surface antibody negative. Next slide. So hepatitis B treatment has changed over the last 5 to 7 years. Used to, we just said they were surface antigen positive, and the only treatment that we did was for the neonate. But now it's recommended that there's a group of people that are high risk for passing the hepatitis B to their fetus, and that the drug, the vaccination and immunoglobulin doesn't work on. Because even with treatment, there's about a 5% incidence of the babies failing the treatment, and so they have chronic hepatitis B. So we went back and looked at this. This is primarily from Southeast Asia, the Chinese literature. If the surface antigen is positive, then we should measure hepatitis B viral DNA. So if the hepatitis B viral DNA is positive, and it's greater than 200 international unit, 2,000 international units per ml, or 1,000 copies per ml, then you should consider treatment. If the individual, we have always known that being E positive, E antigen positive, increases the risk of the patient being a chronic carrier and being more infective. Their infectivity is higher than if they did not have the hepatitis B E antigen. So they lower the amount of hepatitis B in a DNA in our system with the E antigen, and it's lowered to 20,000 international units per ml. And we recommend now treating these people with tenofovir. It's a nucleoside reversed, and I can't remember all that it does. It's one of the HIV drugs too, but tenofovir actually, you can start it around 28 to 32 weeks, and it helps suppress the viral load. And this can be continued up to 3 months postpartum, but it is contraindicated in breastfeeding. If you're not being treated with tenofovir, then you can actually breastfeed with hepatitis B if your viral load is low. Next slide, please. So this is just to remind us that hepatitis B can be vertically transmitted. The baby should receive hepatitis B immunoglobulin and be vaccinated in less than 12 hours of age. and they can breastfeed if the baby is, I said if the viral load was low, they can breastfeed if the baby is vaccinated. Sorry, I misspoke. Next slide. Hepatitis C, I don't know about your lab, but we order hepatitis C antibody with a reflex test for hepatitis C RNA. So if the antibody is positive and the RNA is negative, then it means one of two things. It's either a false positive, or they have had the infection in the past and it's cleared. So if the antibody is positive and the Hep C RNA is positive, then those individuals are considered a chronic carrier. Next slide. So for hepatitis C, the vertical transmission, there's basically no prevention strategies. So we used to think that if your viral load was, greater than, I can't remember if it's 5 million or 1 million, that you were at increased risk for transmission, a vertical transmission, but not all studies have shown that. Some studies have shown that the kids infected versus the kids not infected, their mother had about the same number of copies of the hepatitis C RNA. The other thing, I can't remember, there's 9, 10, maybe 13 different genotypes of hepatitis C. That really doesn't matter to us, and we really shouldn't be genotyping hepatitis C, because there's no genotype that's been associated with an increase or decrease in vertical transmission. We do know that a co-infection with HIV increases vertical transmission. And so the algorithm is not dictated by the co-infection with hepatitis C. If the patient is HIV negative and their viral load is undetectable, then they can have a vaginal delivery. But if they have a high viral load and you offered him a C-section, it's based on the HIV algorithm only, and it isn't based on HIV plus hepatitis C infection. The only other thing that increases transmission is continued IV drug abuse during pregnancy. Why this is, I don't know, except that you can get exposed to more and more different types of viruses. Next slide. So the OB prevention of vertical transmission is hepatitis B has been studied more than hepatitis C, but still what I'm saying for the most part is expert opinion and not based in very much data. But invasive prenatal testing, I would recommend choosing an amnio over a CVS. And the transmission to a fetus from an amnio is very low with vitamin B, with hepatitis B, but we don't know what it is with hepatitis C. But you would think that it would be very similar. Prolonged rupture membranes greater than 6 hours in some studies, 8 hours in other studies, increases the risk of a vertical transmission. But we shouldn't alter obstetrical care to try to prevent vertical transmission. If we got a mole-tip that we're giving PIT to and she's not moving, it's okay to rupture her membranes. And then last is fetal scalp electrode. The fetal scalp electrode is an invasive into the fetal skin. It breaks the skin. And whether or not that increases the risk, we still don't know, but we just try to avoid using it. Next slide. So the biggest, in my opinion, one of our biggest travesties is that now that we have a year after our Medicaid mothers deliver, we have an opportunity to clear pregnant women or postpartum women who are chronic carriers of hepatitis C, and they don't get followed, they don't get referred for the appropriate follow-up. And then the next time we see them, they still have chronic hepatitis C. So chronic hepatitis C has a very high incidence of cirrhosis, and it can lead to hepatocellular carcinoma, cancer of the liver, essentially. But now we have drugs that actually can be used to clear almost 99% of patients. And just so y'all know, that's actually how ECHO was born. There was a guy in New Mexico. He was the only infectious disease doctor treating chronic hepatitis, and people were dying before they could get in to see him. So he set up ECHO with a team of, like pharmacists and psychologists and family medicine doctors and, nurse practitioners. There was a multitude of patients on his ECHO, and they started treating hepatitis C. And actually, it's probably biased a little bit because he probably got the worst cases, but the community providers that actually were trained in ECHO actually had better outcomes than the doctor at New Mexico. So that was how ECHO got started. So please, 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 if you see a patient with chronic hepatitis C, refer them for treatment. And the treatment can be, it's up to 24 weeks, I think. And so we need to get on it after they deliver. And I think that's my last slide, Rachel.